Good morning. Good morning. We'll be starting the health tech competition actually right now. So if we could everyone come and sit down. We have some seats here in the middle. Make friends. It's almost like a Southwest flight. We only have middle seats left. Please come up front, forward. Awesome. Great. My name's Jeff McCalca. I'm with the Center for Health Technology and Innovation at the American Heart Association. This is pitch 2 of our health tech competition. How many of you were with us yesterday afternoon? Okay, so many of you know, well, the participants, that makes sense. But so the way we do our pitches here, we do them in 2 parts. Yesterday, our 5 finalists pitched their business plans and technologies to our esteemed judges. Today, they'll be focusing more on their science, so we can look at their evidence and their validation to make sure they're worth promoting. So we've got an awesome panel of judges, but before we get to that, we've had requests from people in the past. You guys saw this yesterday if you were here, so I apologize for the repeat, but maybe it'll really soak in. We'd like to hear from our past winners. So we have videos from 2 of our past winners. We'd love to show those to you now.
Hello everyone, my name is Atandra Berman, founder and CEO of RCE.
Here we go.
Hello everyone, my name is Atandra Berman, founder and CEO of RCE. We are an AI medtech company that has developed a groundbreaking wrist-worn technology that can detect early stages of heart attacks. We leverage advanced infrared techniques and machine learning to analyze signals through the skin. Now, time is muscle and every minute counts. And while it takes hours to diagnose heart attacks in the hospitals today, we can do the same within minutes. In 2023, we were honored to win the Health Tech Competition Award, and the support was phenomenal. This gave us momentum with strategic partnerships and accelerated our preclinical and regulatory efforts. Bringing our product to market is crucial, and the support and the recognition from the AHA has been invaluable. RCE will be showcasing some of our latest and greatest updates at the 2024 conference in Chicago on November 18th. We look forward to seeing you there.
Awesome. That was 2023 winners. Here's 2022.
What's up, everybody? Yair Saperstein here, CEO and co-founder of AVO, otherwise known as AVO MD. We were the winners of the health tech competition in 2022, and since that time have seen explosive growth. AVO is a software suite of clinical AI tools. As one example of what you could do as a primary care doc, you come into the office, you want to have a look back on your patients as an automatic chart summarizer, chart review that also knows the guidelines, compares your patient data to the guidelines across disease states, including, of course, cardiology, heart failure, AFib, and so on, and then can give you a care guide recommendation of what you actually need to do, pre-draft your notes, pre-penned orders, and the like. So we are very honored to win in 2022 as a way of bringing evidence into the workflow in a way that can reduce burnout and improve the ability to give better patient care. We really thank the AHA for the platform and the ability to compete, and of course for the win, and good luck to all of the participants here.
Outstanding. And Yair will be on a panel tomorrow afternoon if you'd like to learn more about their solution. So at this point, I think we'd like to introduce our judges. If we could go down the row. You all have very, very long credentials. If you could just say your name and where you spend most of your time working would be the best. Eric, can you start for us? Dr. Peterson?
Yeah. Eric Peterson, UT Southwestern.
Craig Beam, Orange County, California.
Lisa Sunan, head of AHA Ventures.
I guess I could repeat.
Ken Nelson, MedTech Advantage Fund.
Ken Nelson.
Hi, my name is Murad Fudim. I'm at Duke University, and I'm a heart failure cardiologist.
All right, we're going to have to start over again, I think. Can we go all the way to this side of the table again?
Yeah.
Or do you just want to use mine?
Yeah.
Can we just do a handheld?
Yeah. Eric Peterson, UT Southwestern.
Craig Beam, Orange County, California.
Lisa Sunan from AHA Ventures.
Ken Nelson, MedTech Advantage Fund.
Murad Fudim, one of the heart failure cardiologists at Duke.
Asif Ali from UT McGovern in Houston.
Tiffany Powell Wiley, NHLBI.
Mike McConnell, Stanford University.
Star Jones, AHA National Volunteer.
Does anybody have any hand sanitizer? I'm joking. All right, so awesome. We're so excited. So here's the format. We call companies up. They get 7 minutes to pitch. Judges have 7 minutes for question and answer. As you may have noticed yesterday, I'm really uptight about the time. I think that's the only way we can keep it fair. And if you were here yesterday, I apologize, but so I have more than one child. So yesterday, I got a picture for Milo. So today, we could get a picture for Caroline. That would be really cool. 1 second. All right. Can we all say hi, Caroline? Hi, more energy, more. All right, great. Thank you. All right. So I think we're ready to begin. Judges, are we ready? Finalists, are we ready? Oh, and we have a new clicker today, so hopefully that's even smoother than before. So first up today, Flow Medical.
All right. Thank you so much, Jeff. It's truly an honor to be here. I'm really excited to be pitching to this esteemed group of cardiologists and healthcare providers on behalf of my co-founders. I'm an interventional cardiologist at the University of Chicago. I work very closely with my partners in crime, Jen Fried, who's our CEO, and Oz Ahmed, who's an interventional radiologist. Don't hold that against us because we work with radiologists. Here's the problem. Pulmonary embolism, huge public health issue, 3 million deaths per year. During this 1 hour presentation alone, about 350 people will die of a pulmonary embolism. It affects everybody. There's no discrimination when it comes to pulmonary embolism. It is also the #1 cause of preventable in-hospital mortality. People like David Bloom, a young, healthy journalist. People like Serena Williams, a healthy tennis player at the peak of her career, multiple pulmonary emboli, also a leading cause of maternal mortality. But despite this being such a huge problem, we have very limited tools. We're living in the Stone Age of interventional tools to treat pulmonary embolism. The standard of care for invasive management of pulmonary embolism simply misses the mark. We're using devices that were developed for other indications. These are small catheters that were developed for arterial thrombosis. We're using them in pulmonary embolism. They go past the clot. They don't make good clot contact. Additionally, these devices give us no guidance on how much drug to give. We're using very potent antithrombotic and thrombolytic drugs here. And we have no idea, despite it being 2024 and having been doing these interventions for 20 or 30 years, how much drug to give. Despite the fact that we have these tools and we don't have a good feedback mechanism, we still don't know. We have high readmissions. Too little thrombolytic drug, thrombus remains. Too much thrombolytic drug, bleeding complications will occur. Both of these are critically important complications, and both of these lead to significant morbidity and mortality. So we've developed what we think is a solution for this problem. This is the Flow Medical catheter for invasive management of pulmonary embolism. We've designed it specifically for the pulmonary vasculature. This device has a novel scaffold that enables us to penetrate clot more effectively, delivering the thrombolytic drug directly to the source, enabling us to use smaller doses potentially and achieving better outcomes. Most importantly, what we think is the most exciting really is that we're finally going to have a way to have personalized medicine, to understand at what point the patient has improvement in their pulmonary artery pressure, to know when you can stop the drug, rather than just give the same dose for every patient despite their comorbidities. I'll walk you through just a brief overview of how this device works. This is a device that is advanced over a wire. It's a 9 French device, has a self-expanding scaffold that penetrates the clot. So the device is advanced over the wire. A high-pressure pulmonary angiogram is performed, so you're able to visualize where you're going with this device exactly, placing it directly into the largest proximal thrombus. At this point, the device is then advanced through the largest proximal clot. Unsheathed, it's adjustable in length, so this would be one SKU, one device for every patient. The lytic is then bolused and dripped through the scaffold. This is hollow tubing, so there are laser cut holes in the scaffold allowing us to drip directly into the clot. But what's most exciting is we have a fiber optic sensor built into the catheter to allow us to monitor pulmonary artery pressures in real time, so that we can understand, both on the right and the left, when the pulmonary artery pressure decreases to a level where we know there's going to be less risk of hemodynamic decompensation. So this is a huge public health problem. We covered that. There's also meaningful disparities in outcomes across ethnicities and genders. Still, in 2024, outcomes from pulmonary embolism are worse in black and brown patients as well as women. This is a problem that could be attributable to access to care, being able to perform simple interventions across the country, across the world, and we think we have a solution that can solve this. There's a treatment gap of advanced therapies. If you compare this to a more mature market like myocardial infarction, roughly 90% of patients will have an intervention when they come in with their STEMI. When a patient comes in with a high-risk pulmonary embolism, only about 15% of patients, despite us having good data at this point, will have an intervention performed. Catheter-directed thrombolysis has good data, lower 30-day and 90-day mortality. There's improved right ventricular recovery compared to anticoagulation alone, and bleeding complications are really not much more than just standard anticoagulation. So these devices are safe and effective. Let's talk about the numbers here. So when it comes to readmissions after an acute pulmonary embolism, nearly 1 in 5 patients will be readmitted within the first 30 days. This is a huge burden on our healthcare system. The most common causes of readmission, not surprisingly, heart failure and pulmonary hypertension. These patients are coming back due to undertreatment or complications from their pulmonary embolism. We know that when a patient leaves the hospital with more residual thrombus, when their clot is undertreated, they will come back more often than patients that have more effectively treated pulmonary embolism. If you're in the top quartile of patients that have a pulmonary embolism, you have an almost 60% chance of coming back into the hospital at 6 months with an adverse event. Additionally, we know that pulmonary artery pressure monitoring is a very good metric to understand recovery of the right ventricle. In all of the seminal studies in pulmonary embolism, there's been a roughly 25% reduction in systolic PA pressure in all of these studies across the board. So we have a goalpost. We know what to shoot for, and we're able to use our monitoring system to achieve that and understand when to stop the thrombolytic. When we actually measured this at the University of Chicago, you can see that there's a very heterogeneous response to thrombolytics across the board. Women and men behave differently. Different ethnicities behave differently. Some patients will have this 25% reduction in 2 hours, whereas some it may take much longer. In the last few seconds, I just want to talk you through a case. This is an animal study that we recently performed where we were able to use our device and give just 3 milligrams of TPA. So this is 3% of the dose that we would typically give for a myocardial infarction or a pulmonary embolism, a very low dose, and importantly, we're able to monitor those hemodynamics in real time. Baseline pulmonary artery pressure 20/11, PA obstruction rises acutely to 40/20, and then with reduction in the pulmonary artery obstruction, we see that pressure return back down to 20/10. So we think that we've created a new standard of care for invasive management of PE. We're creating a simple, safe solution for widespread adoption, and most importantly, we're bringing precision medicine to cardiovascular disease. Thank you.
I wasn't so scary, was I? No? That's good. Nice job.
Thank you.
Excellent. Okay, 7 minutes on the clock for question and answer. I'm more nervous about managing you than them, frankly. So who's got the first question? Dr. Asif?
Great talk.
Thank you.
We previously this morning talked about disparities and inequities in different cohorts of patients, especially on skin tones, genders, race, age, obesity. What I didn't see in your data exactly was the data behind all of those different cohorts, because it takes a big N to be able to cover those number of variables. So what type of patient populations have you studied as a whole, looking at clinical research, inclusiveness, and the diversity in your populations in your
It's a great question, a very important question. And I think to be honest, we don't have excellent data on disparities in pulmonary embolism. We just know that there are disparities in pulmonary embolism. So understanding why those disparities exist, we don't have excellent data on. But I will say with our device, we hope to be able to collect pulmonary artery pressure across thousands of patients so we can understand disparities, at least in improvement in pulmonary artery pressure over time, based on these factors that we don't fully understand. So at least we'll know, in maybe a 65-year-old woman compared to a 25-year-old man, it takes 8 hours versus 4 hours on average to lyse the pulmonary embolism.
But just to be clear, you haven't done those studies quite yet.
Well, we're pre-market right now,
Pre-market,
so our device is not FDA approved at this point, so we're currently going through FDA approval process.
Thank you.
Yep.
Dr. McConnell, Dr. Phelan.
Okay, I obviously love the topic of pulmonary embolism, and so big unmet need. I wanted to understand a little bit better how you're comparing your technology to, so there's systemic delivery of thrombolytics and catheter delivery of thrombolytics, and I couldn't quite distinguish how you're comparing, and then as you're doing your animal studies and your sort of FDA proposal studies, what's your comparison? How much data do you have?
Yeah, great
What you
question.
think you're going to improve on current standard of care?
We're living in a really exciting time in PE therapy, as you know, better than anybody. Right now, there are multiple multi-center randomized controlled trials going on. Probably the most important one of those, led by Dr. Sista, sitting here in the front row, which is called PE Tract. This is going to be looking at catheter-directed therapies versus anticoagulation alone. We think that having the results of these studies alongside the other industry-sponsored studies will give us finally Class 1 evidence to upgrade our guidelines to make any of these therapies Class 1 for patients with intermediate, high, or high-risk PE. Once we have that data, we'll be able to offer these therapies, we think, across the board to patients that come in with these symptoms and these hemodynamic issues that make them high risk. Once we have, the patient population increase from that 15% up to what we think, will be rough, in that 350,000 people a year that probably are eligible for these procedures, then I think we'll start seeing comparisons between different devices and different modalities such as large bore thrombectomy or catheter-directed lytics. So I don't have a perfect answer for you, although I can say that the data is coming 2027, 2028. I think we're going to have a much better answer for that question.
Outstanding. Dr. Murat?
Thank you. So I understand you might have human data, and So the question then is, what will the FDA need to approve your device, human data device, and what will the market need to see to choose your device over the others? What do you think?
Yep. So currently we're pursuing a 510(k) approach to our approval of our device. So we won't be conducting a large 500 patient randomized controlled trial similar to what PE Tract is doing. However, we are going for a pulmonary embolism indication initially, which will make it so that we need to essentially show safety compared to the current devices. So we're planning around 110 or 120 patient single arm study to study outcomes such as right ventricular RV-LV ratio recovery, as well as some secondary outcomes such as PA pressure reduction and others. Obviously, bleeding is going to be a huge concern, and we think that by having personalized therapy and reduced doses of TPA with our monitoring system, we're going to be able to show that we're able to potentially lyse clots faster in some patients, although there may be a group of patients that may take longer. So we're hoping to look at both acute and chronic outcomes, things like readmissions, things like bleeding risks and other issues down the road where we may be able to reduce some of these readmissions that are happening because of either under or over treatment.
Excellent. Lisa?
Hi, nice presentation.
Thank you.
Is this the big problem that the doctors are trying to solve? I know that thrombolysis has a lot of negative side effects in some patients, and they're really the rushes to find alternatives. Are you going to compare to other types of therapies what you're doing?
Well, what we're hoping is that the guidelines will, or that these big randomized controlled studies will tell us the appropriate patient population to be using these therapies for. So once we identify that intermediate, high, and high-risk PE patients benefit significantly from any of these therapies, then it's our job to compare device to device. But I think that within catheter-directed thrombolysis as a therapy, we're living in a time where we have no feedback, we have no way of understanding, how much drug to give, and that is an important problem. These patients will stay in the ICU sometimes for 12 or 24 hours. I think there's a world where we're able to deliver these in a postoperative area. We're able to avoid ICU stays completely. We're able to offer these therapies to hospitals in the community that may not be adept at doing large bore thrombectomy procedures with 24 French sheaths and managing the complications that go along with that. So we think that it's just time to have a catheter-based therapy that's simple, but also precision medicine-based, and understanding that we can do this in a way that's it's scientific and not just giving the same dose of thrombolytic to every patient and then dealing with the complications that will inevitably occur. So yes, it's a huge problem, and our devices haven't changed in CDT for the most part, with the exception of maybe one other device in the last 20 years. So it's time for an upgrade.
Outstanding. We have about 20 seconds left. Ken.
Yeah, so I know yesterday when we spoke, you went through the reimbursement pathway a little bit. Could you share that with the group? And I think you mentioned it's like a $40,000 reimbursement. Is that?
DRGs for pulmonary embolism interventions are healthy for hospital systems, and so hospital systems do well with PE interventions, whether it's a pharmacomechanical approach or a thrombectomy approach. There are very healthy margins for hospitals. So depending on the DRG code and the comorbidities of the patient, it's reimbursement is quite good for hospitals.
Outstanding. Thank you so much. Round of applause, please. For Flow Medical. Outstanding. Judges, are you entering your scores into our fancy electronic solution that we have? I see conversations happening, deliberations. I need a thumbs up when we're ready to proceed. Are you guys talking sports over there? Or no? All right, we're good. Okay. Oh, you're probably going to want this as well.
Oh, sure.
All right. Welcome to Hecka Heart.
The green is forward, right?
That's what I understand.
Hi, and thank you for this opportunity. My name is Lior Jaffe. I'm a heart failure and transplant specialist. And I'm here to introduce Hecka Heart, the most advanced heart failure care anywhere. Heart failure is one of the biggest problems facing our healthcare system. And something that's really frustrating is that we have the right therapies to treat this condition, but most patients aren't even on the medications. Less than 10% of patients are on the 4 classes of guideline-directed medical therapy, or GDMT, and only 1%. That's 1% of patients are on all the right doses. The traditional reason for this breakdown is the fact that our existing infrastructure is not tailored for chronic care management and GDMT optimization. I can take you through all the breakpoints in this traditional flow of patients, but I'm not going to. I'm going to give you a different story. I'm going to tell you that we're just doing this way too slow. We know that GDMT works. Every new medication added gives years extra of life to a patient and gives them the best chance of heart recovery. But that's only part of the story. Recent data suggests that timing matters, and getting all of these classes of medications on as quickly as possible is key to maximizing outcomes. There is now no existing solution that safely enables rapid, simultaneous initiation and uptitration of GDMT. That is until now. Hecka Heart is transformative. It is a virtual-first heart failure clinic. At the core, we are dedicated to providing the best possible volume and medication management to heart failure patients. Other platforms may be built on static protocols. We build those protocols dynamically for each individual patient. We use real-world experience, augmented by AI, overseen by heart failure specialists, and enabled by our clinical care team. Hecka fits right into current practice. Once a patient is identified, they go through this rapid virtual onboarding phase. This is when we get to know the patient. We find out barriers to care, whether they be financial or social. We make sure that they get the remote patient monitoring devices and that communicate directly with our platform. And here's where it gets really interesting. We use a proprietary risk assessment score to develop bespoke, dynamic titration plans for each individual patient. For instance, based on a patient's blood pressure, we can determine what interval we use to up-titrate medications and change the doses. And based on things like their kidney function or their potassium, we can determine how many safety checks they need. And the best part of this is we are finally moving past the one-size-fits-all era of heart failure management. And every new patient enrolled in our platform improves our algorithm. Once patients are in the optimization cycle, we anticipate a lot of the barriers that they face with multiple med adjustments and the safety checks. So we provide them with the support they need, whether this be prior authorizations, whether we do med reconciliation. We give positive feedback and nudges for compliance, and if they have any symptoms, we deal with that as well. Underlying all of this, we make collaboration with the patient's current clinician central to our practice. So we use the face-to-face encounters to improve this optimization cycle, and at the same time, we give back like longitudinal data, trend analysis, clinical summaries, and actionable next steps that enhance the clinician-patient relationship and help to build trust in our platform. Okay, now that I've told you what's possible, let me tell you how we do the impossible. Safe, high-intensity titration in an outpatient setting. So in order to go really fast, you need guardrails. So we need to find a way to identify both dehydration and volume overload. We've partnered with Withings to provide patients with a specialized blood pressure cuff that takes multiple sequential readings with them both seated and standing. This allows us to create a model of cardiovascular adaptation to position changes. On the same exact device, we can also record patient-reported symptoms. Together, that allows us to screen for orthostatic hypotension, which is one of the major drivers of GDMT intolerance. It then allows us to proactively adjust loop diuretics or withdraw them, which don't have any survival benefit, and then we can also encourage them to hydrate. We use a basic weight scale, but we add precision by giving practices the education and the equipment to do point-of-care ultrasound, which we can then use to calibrate our weight trends and detect true volume overload events while reducing noise. For patients that are higher risk, we can incorporate multimodal inputs with PA pressure sensors, impedance, and next generation devices. In other words, we love all the fancy new stuff, but we can also do a lot better with the simple stuff. All the trial benefits plus the elegance of rapid titration that haven't been translated into the real world, we can deliver that. Clinicians, we don't cut them out of the loop, we elevate them. Patients get better quality of life and better chance of heart recovery. Systems improve access to care and quality metrics. Payers pay less. This isn't hypothetical. We've been able to lower the time to average GDMT optimization to only 8 weeks. This is far better than even the most ambitious trials like STRONG-HF. This tracks with cardiovascular benefit, and across the heart failure system, the impact is astronomical. We are available, ready to partner with forward-thinking practices. We're the only virtual clinic to deliver the gold standard of care, and together we're creating a new paradigm that will save the lives of millions.
Okay. All right, nicely done, nicely done. Round of applause, please. The Blue Angels went by, cameramen were going by. Good concentration. Judges, who has a question? Dr. Peterson, thank you.
Yeah, I'm curious, how many states are you licensed? I assume you're doing the prescriptions, so you've got to have a practicing doc there. How many states have you covered?
Yeah, sure. So we're in like 4 states right now, but we have ways of like quickly ramping that up. Okay,
and a quick follow-up is the doctors are obviously giving up revenue for their patients or follow-up. How is that, what's your pitch to the docs? Yeah.
I love that question. So I don't think doctors aren't giving up revenue. We're actually, when we're talking to practices, we're going to actually facilitate more like face-to-face encounters because of all the data coming in, they can do quicker encounters. They basically have the note pre-written, and they can even do virtual encounters because we enhance these visits. So they're actually able to improve access and see them more regularly. Also, from a financial standpoint, in a pay per, in this world, which pay per service, we also enable CCM and RPM billing, which is really great for cardiology practices. Most aren't doing that.
So, can you talk a little bit more about the risk assessment tool you've created and what's it based on? Does it utilize social measures as a part of that? You mentioned social measures that you collect.
Yeah, I love that. I love that. So right now we're building out the risk assessment tool based on currently available data in clinical trials. So for instance, we're using like the risk of hyperkalemia, and we're using like the risk of hypotension, both from like my own clinical practice as a heart failure specialist and trial data, and we're kind of feeding this into the initial iteration of the model. Now we are like we're a small startup. We don't have a ton of patients. So the idea from that standpoint is as we get more patients and we collect all this data, we can be far more granular. And social determinants of health and the race of the patient as it applies to this risk scoring system is something we're going to be looking a lot at. And we're hoping to build this as a precision medicine platform where not every patient gets the same like heart failure titration.
Dr. Asif?
Well said. Big problem. We look at patients over 65. For CMS, it's the number one reimbursements and hospitalizations. CHARMS heart failure showed us also that GDMT, huge lack. But how, with your digital solution, are you addressing the health inequalities and inequities in your digital health solution? Because the cohort of patients that actually need this are in those zip codes, right, that are usually areas that are challenged, especially with digital health solutions, and that social determinants of health that goes in.
Sure. I love this question, and there's multiple parts to it. So first of all, we're actually partnering with smaller practices. That's kind of like our first target model. So we want to really we're really going away a little bit from like the big integrated health systems. We'll get there. But like we're targeting smaller practices and rural practices, especially around where I am. I'm in Western Mass, and so we're targeting Berkshire practices and stuff like that, if you know the area at all. And then we're engaging, these patients are really hard to engage. That's, I think, where the speed of this comes in. So first of all, we've shown in our pilot project 90% engagement. And I think one of the keys is that we're moving very quickly. So there's less time to like drop off or get disengaged. And also patients that are on like optimized GDMT, like they feel better very quickly, and that like feedback cycle helps with their like continued engagement. And then we have like a tail period where we follow these, re-engage, provide positive feedback, and positive feedback is something that we don't do a lot of in current practice. We can do that, where we can really activate these patients and keep them involved. And so we love like going out into the community. I am a community heart failure physician. These are my people.
Your 90% engagement that you talked about.
Yeah.
How have you gamified this to make sure that engagement's happening? What's your gamification?
It's not a gimmick.
Okay.
So
no,
I
not
think,
a gimmick. I said gamification.
Oh, gamification. Sorry, my bad. We don't really use gamification. We use positive feedback and multiple like points of like re-engagement in the patient, and we found that because we're changing the medications like more rapidly, that they are like almost by definition like engaged in this process. There's a big difference between engagement in a patient who has their GDMT titration spread out over 6 months, which is probably even less than the average, versus doing it in 8 weeks. And the fact that really a lot of these patients are able to be pulled off of their loop diuretics, they're not getting rehospitalized, they're not going like on the bathroom all day long, like they feel better, and that's why they're engaged with us. So it's not really a gamification model, it's more like a reinforcement model, and it self-reinforces.
Great. Dr. McConnell?
Yeah, I think we all totally understand the value and importance of doing this in this high-risk population. But as you know, there have been a number of other companies promoting, rapid GMT adoption in heart failure patients particularly. So could you go back a little bit. What's the innovation difference in your sort of science and implementation that really differentiates you from what's out there on the market?
Sure. Maybe let me push back a little bit on that, because we know the competition, and like we've met with the players, and a lot of that is built on static heart failure titration protocols. And usually it's like, you know, I mean, the standard is every 2 weeks. As I know of, and unless somebody is doing this that I don't know of, nobody's doing like dynamic, bespoke titrations for every single patient. We build those from scratch, and we track our outcomes. We track things that happen, like if hyperkalemia happens, if a hypotensive event happens, if a rehospitalization happens, we track that and we feed it back into the model. So our model is getting stronger while everyone else's model is just stuck at this one level. That's how we are different.
Okay, we're going to have to leave it there. Thank you so much.
Yeah, appreciate
Great job. Thank you so much. Judges, if you could record your scores, please. Just a couple housekeeping items. You all came through a pavilion of amazingly innovative companies to get here for this competition. So perhaps after the competition, I encourage you to stop by and say hello and learn more about the solutions that are being shown here. And I just want to start teasing out that at 4:15 we'll be doing the award ceremony that reveals, you know, how this all turns out. There you go. Power for Medical.
Is this the clicker?
Clicker should work. Green means go.
So hi everyone, my name is Robert Herman. I'm the Chief Medical Officer and co-founder of Power for Medical. It was actually my brother presenting yesterday, despite we looked similar. But I want to show you why PM Cardio will become the standard of care for managing acute MI worldwide. But first, I want to introduce you to Juan. Juan presents like 25 million Americans each year to the emergency department of a spoke center. This is his ECG with chest pain. This is his ECG admission. And unfortunately, in this case, Juan was incorrectly discharged because of a normal-looking ECG. The monitor, the ECG device, didn't actually help in making the correct interpretation. And unfortunately, after 6 hours after discharge, this is how Juan comes back. Now the diagnosis is quite clear, with widespread ST elevation and a proximal LAD occlusion identified in the cath lab. Unfortunately, Juan's discharge diagnosis now is heart failure with reduced ejection fraction. How can we use technology to prevent more these cases from happening? And while Juan's case is a very sad one, it's unfortunately not rare. The ruling pathway for patients with ST elevation myocardial infarction are suboptimal, and they have two big problems. First, there is a lot of false positives, especially in the pre-hospital settings where a lot of these patients actually initiate, where 40 to 50% of STEMI alerts are actually false positives, causing a lot of burden on the interventional cardiology teams. Clinically, more important, 1/3 of these patients with STEMI actually present without typical ST elevation, causing misdiagnosis. And of course, this has a big impact on their time to PCI, which is delayed, and therefore these patients have a higher 1-year all-cause mortality. How do we solve this? Well, this is what your standard STEMI network would look like. You have patients initiating in a pre-hospital setting in a spoke like Juan, or in a PCI hub. So what if in this setting we could just record an ECG and use AI to get an immediate interpretation and diagnose STEMI as early as the first point of care setting? And if the diagnosis gets detected, these patients could be driven immediately to the cath lab for primary PCI. Well, we've built this system, and for a patient like Juan, instead of showing a normal ECG interpretation like the normal monitors you already have on the ECG devices, we would actually show a highlight of the diagnostic features of this ECG associated with coronary occlusion, and make sure that Juan doesn't end up with terminal heart failure as a discharge diagnosis. Well, this system is called PM Cardio, and we've built it to facilitate and streamline care for chest pain patients presenting from virtually any setting. And the only thing you need to access PM Cardio is actually in my pocket. It's a 12-lead ECG. We support any format of a 12-lead ECG, even if it's image-based. So in the pre-hospital setting where a lot of these ECGs are recorded, they're not connected to the healthcare health system, and the phone. You just take a picture of the ECG and you can get an AI interpretation within a couple of seconds. What is the value proposition for the health system? So we've built the system with health equity in mind, providing really democratizing access to cardiologists and really making this power available at the first point of patient contact. We're focusing on acute triage, fast management of the patient, because it's actually a platform that notifies cardiologists further downstream. We're focusing on interoperable pathways, so any data in any form is actually being inserted into the platform for fast management. And we also save a lot of costs in terms of reducing false positive cath lab activations. Now, let's talk a bit about the science, why this is important. Well, actually, the AHA guidelines already recommend STEMI equivalents that are frequently misidentified at the first point of patient contact. Conventional STEMI criteria are frequently picked up, but there is a lot of patients presenting without typical ST elevation, like Juan over here, who get a late diagnosis and therefore delays to treatment. To tackle this, we've developed an unbiased AI model on a large data set of tens of thousands of ECGs with clinically validated angiographic outcomes, and we've developed a deep neural network that detects and doesn't focus on specific ECG features like ST elevation, but really asks the underlying question: does this ECG show signs of acute coronary occlusion on the angiogram? And now let's talk a bit about the evidence, because this is a science part of the pitch. And I'm very happy about this, and this is really what drives me. I want to put AI to the same level of scrutiny like we're used to in the medical field with drugs and invasive devices. To do that, we've put together a large study of 3 sites, 2 of them in the US, where we validated the AI model in over 2,000 patients. And we've showed that the sensitivity of our platform at the same specificity is twice as high compared to the standard of care. This study is already published in the European Heart Journal Digital Health. And don't take my word for it, but take the word of the many sites that are actually externally validating this technology. Many of these are being presented at the AHA on Monday with impressive results in various subpopulations, really consistently showing the huge accuracy of the system and also the reduce of false positive cath lab activations. We've also prospectively implemented this system because it's fully cleared for clinical use in Europe. And in a 3-month period, we were able to reduce STEMI alerts, false positive STEMI alerts, by 68% without missing a STEMI patient. And for STEMI equivalents, we were able to get these patients into the cath lab very fast compared to a historical period. And lastly, I want to show you a randomized controlled trial that is currently ongoing in Turkey, enrolling patients into an AI-assisted arm versus standard of care with the primary endpoint of all-cause mortality or unplanned hospitalization at a 1-year follow-up.
Okay.
Thank you for your attention.
Thank you so much. Powerful. Well done. Okay, judges, who has a question? Ms. Jones.
I'm a little biased because this was me 13 years ago. I presented, but I had an amazing standard of care. And Dr. Valentine Fuster is reading my charts. This seems like it would be an equalizer for someone who doesn't have Valentine reading their charts. The ability to get that same standard of care where AI interprets it no matter what your race is, your location is, no matter what your income level is. Am I interpreting that correctly?
That's an excellent question, and this really highlights one of the key aspects of our system. We've built it with health equity in mind. We're making this accessible in any location where an ECG is available in paper form. You can have a 30-year-old ECG device producing a paper ECG, and you can actually get access to our system. And we've also built a system with the racial, ethnic, and gender inequalities in mind, where our AI models doesn't look at anything but the ECG waveform.
Dr. Ali?
Great presentation, very necessary, and good use of AI in this area. A lot of companies that are trying to do this as well. About 4 companies already kind of talked to me about this. But my question here, the term bad data in, bad data out. So what if the technician doesn't get the EKG exactly right? I had a patient recently, just the amplitude was doubled. And so the EKG that I was presented was an EKG with the amplitude doubled. So if I took a picture of that, AI would interpret the error of the amplitude based on the tech doing it. I had to tell them to go back, reduce the amplitude to 10 instead of 20, and it ended up being a normal EKG. So my issue, or my question to you is, can your algorithms for AI pick up variances even if they flip the leads or the amplitude? So if the data is bad, is the AI only interpreting the data it's given, or will it tell the human who created the error of collecting that data to repeat the EKG, like I would if I saw an erroneous EKG?
Yeah, that's a fantastic question, and there is a lot of issues with proper acquisition of ECGs, especially at the first point of patient contact. We do a lot of validation here, and there are some errors that the AI can just account for. Why it can account for it is because in the training process, we actually apply a lot of augmentations. So in data that is actually accurate, we can modify the ECG waveform and make it robust to these errors. But we are now recently also working a lot on indicators of quality. So we can actually highlight these ECGs with very abrupt lead reversals causing differences in the waveform to notify the user to record the ECG again.
Thank you. Is your solution bound to a phone, a software package, or is this something you can actually integrate into the existing Philips system we, for example, use? The reason I ask that is that while you show me a paper, 99% of the hospitals in the United States, from what I know, it gets fed into the EMR near instantaneously. So you can actually have the EMR then have augmentative solutions. Let's say Epic comes up with a solution that could integrate you or build their own AI solution to do the actual second read.
Yeah.
Because I agree, the paper read tends to be actually often not helpful, but you will get the electronic read in a second. So do you integrate, or is that not possible?
Yeah, so our system works with digital data as well. We actually, in fact, have integrations with both ECG defibrillators in a pre-hospital setting. So a paramedic in an ambulance in Europe is pressing a button on the ECG machine, feeding the ECG directly to our platform, which then is notifying cardiologists further downstream in the PCI center. We have integrations also with in-hospital ECG devices like GE Muse. So if your hospital has one of those systems, we can digitally integrate, and there is no need for the scanning part. But still, a lot of sites actually work with paper data, especially if it's being sent from a referral center, from a rural setting.
Dr. Pearson.
I thought I heard yesterday that you also are looking at other utilizations other than diagnosing myocardial infarction.
Yes, so STEMI is a pathway we sort of start with because it's well protocolized. There is a lot of quality tracking in STEMI in the US, but we're also focusing on other pathways like detecting left systolic dysfunction, left ventricular systolic dysfunction directly in the primary care setting, and getting those patients earlier to the primary hub, and also arrhythmias.
Ken.
So I've been following you guys for a while. Love the work that you and your brother are doing. When you think about the ECG as a window into detecting and predicting many different things, including heart failure, of all the things that you're working on, what do you think is going to have the biggest impact on medicine?
Well, I'm a bit biased because I really started the STEMI pathway and looking at the hidden STEMI that is not manifested on the standard 12-lead ECG. I believe there is thousands of excess deaths in that pathway, while a lot of the cardiology conferences make it seem that STEMI is a solved problem. It's not really solved, and I think, to me at least, this will have a huge impact on getting these patients earlier to the cath lab, preventing heart failure and preventing poor prognosis of these patients.
Lisa?
So, sorry if this is the wrong way to ask this question, but is it really getting people to the cath lab faster, or is it just getting them released faster if they're fine? Because they're going to do the troponin tests and the other normal tests before they're going to spin up the cath lab, right?
Yeah, so that's a good question. And the role of the ECG in the management of acute MI is really the fact that you can record it within 5 seconds or within 20 seconds, and you get a direct rule-in of these patients. While a lot of these patients are not missed in terms of they're not discharged like the case I presented because of the troponin elevation, to get the patient fast to the cath lab is the only thing that matters in STEMI. So it's 2 hours, and this is where AI ECG interpretation comes into play.
We're going to have to leave it there.
Thank you
you so
very
much. Nice job. Cool. Judges? Oh, yeah, you're going to want your phone, right? Don't take mine. Okay. Judges, we're in progress. Also, just want to remind everyone that we're going to have programming for the rest of the afternoon here on this stage and all day tomorrow, including a showcase of, is it 16 different innovative companies? So join us tomorrow. Well, are we all set, everybody? Okay. Proton Intelligence. You're going to want that. There you go.
Okay. All right. So presenting on Proton Intelligence. So we are a continuous potassium monitor seeking to turn the invisible fear of invisible potassium into something visible and actionable. So I'm Steve Pham. I play an emergency medicine doctor on reality TV shows. And in my emergency department, when patients come in with hypertension, heart failure, kidney disease, they're often optimized on these medications, many of which you're familiar with, right? They bend the cost curve, they are effective, but they still come in with arrhythmias, and it's not infrequent. And oftentimes it's from potassium. It's to the point where I reach for my potassium medications as soon as possible when I see these patients, or else they come into crash dialysis or sudden cardiac death. And I believe that problem is because patients on these medications, we don't know if they have a potassium problem or not. So fear of potassium is the barrier to cardiorenal care. The solution is a patch like a CGM. It's the first ever continuous ambulatory monitor for them. And it acts and is housed just like a CGM, where you have a sensor lead with chemistry specific to potassium embedded into the interstitial fluid compartment. And you can get data like this. Now, this is not what we intend to show to patients or providers. I think it would freak everybody out. You wouldn't need to know this kind of data, but it's pretty cool. We think that for a healthy human, you'd see a flat line. During a dialysis session, you'll see it be stable and then dive down and then come back up right after the dialysis session completes. And in someone who you might be diuresing on Lasix, slowly going down, perhaps creeping down below the 4.0, the new 4.0 danger zone. And so this is information that we want to make visible that might be useful for these patients' care. The value proposition is threefold, and it's really to break down barriers to cardiorenal care. First, for the first time ever, you have the ability to deploy a potassium test at the patient's home, just like you would with a Zio patch. We think this is transformative. We know that rural patients managed by companies like Hecahart have to go to get their potassiums at Quest Diagnostics, and if you're doing 5+ tests over the span of 8 weeks, are you really going to do all 5 of them, and potentially even more than 5? So we also know it's reliable. We do not have a hemolysis problem. We don't actually go into capillary blood. We're in the interstitial fluid. So no repeat tests, real-time insights as well that show you that's reliable. And we're actionable. How do I know that? We all know what to do with hyper and hypokalemia. That was never the problem. The problem was having the data visible to actually do something about it. All right, so what we're planning to do is essentially start with CKD first for RASI optimization, MRAs, and then the upcoming aldosterone synthase inhibitors that are coming online. Second is going to be fluid management, because on the hypokalemia side, you're going to have these patients on diuretics. Some may be using SC Pharma, auto-injectors, things like that, where you're flying blind. And then hypertension, the big piece of the pie. But as a platform play, we're not just potassium because we have proof of concept on sodium, and we also can probably capture about 80% of analytes in a BMP, right? Basically anything that's charged and ionic. So the science behind this is quite simple. It's actually very elegant. We decided not to reinvent the wheel. We're doing a lot of the same things that CGM does, which is embedding chemistry specific to the analyte on a substrate. The difference is that red box. We are not using enzymes to process glucose that then generates a redox reaction and leads to a current. Instead, we're using a voltage-gated ion channel. This is not rocket science, right? We've known about voltage-gated channels for a long time. It's the industry standard for any lab diagnostic, in fact. And so that's all we did. And you would not believe how challenging this is. This is reinventing the wheel, even though the wheel has already been invented. It's very hard. So what you're seeing here is a chemical bath in that little black bucket thingy, and we're dipping in a voltage-sensitive sensor to have what's called dip coating, so that the chemistry is embedded and bonded in a way with high quality. And you have to have extremely high quality to get this working right. And then we put it into a CGM housing. So you have an applicator, and you insert it through a retractable needle, and voila, you now have a wearable potassium monitor. So very elegant, relatively painless. No other existing competitor has clinical utility. Finger sticks, we know, don't work. Many, many competitors in the last 10, 20 years, and hemolysis is the big problem. Non-invasive AI-EKG can classify, but it cannot measure. And it has problems with race. And we know this because EKG changes sometimes are specific to race. So we have big problems there, and none of them, they have breakthrough designations, none of them yet have FDA clearance anyways. Optical sensors, even worse, right? So you've got skin color blocking a lot of this optical sensor, and Alio, you know, I think they had really good intentions, but the biggest problem with Alio using optical sensors is that you have to have super thin skin to get any kind of pickup here. So this only works on AV grafts. That's not going to work for any of that pie that really, really needs what we can deliver. And then lastly, the incumbents. The CGM manufacturers, we've got upcoming aptamer stuff, very cool stuff, but they have to reinvent the wheel. They've never done this ever before. So that's a complete IP white space for us. So we've filed 7 patents, 4 more pending. The evidence. So how does CKM compare? So what you have on the red column is basically showing we are exactly identical to lab standard. That's because we're using the same thing. It's just voltage-gated channels. Now, when you actually look at it in a chemical bath that is simulating serum, you see now accuracy that is incredibly high. So what you're seeing are these MARDs, which are basically relative differences. They're just deltas. And the deltas are very low, 3.34 to 4. CGM's industry standard, 10%. Finger sticks, 5%. We're better than CGM's already. Sensor data is also extremely reproducible. So we have here in one bath about 30 sensors. And pay attention to the shape of the graphs. They're all the same. They're just offset a little bit. That's a calibration issue. That's not a reproducibility issue. Calibration is an algorithm problem. We're going to solve that with our first in human to modify the algo to change the calibration.
Great. We're going to have to stop there. There'll be more in questions. Okay, you're really into it. It's good. Round of applause, please.
I had a lot more data.
That's my job. That's the only reason I'm here, really. Judges, Ken.
Yeah.
So when you think about the patents that Dexcom and Abbott and Medtronic already have in the CGM space, it looks very similar to a CGM. How are you going to get around those patents?
Yeah. Teeing me up for this. You already know a little bit about this. So the patent space is actually not specific to what we're doing, but what they've done is they've patented the applications of what we're doing. So it's not actually the core technology that they have defensible. They're just predicting what would you do if you had a potassium. So if you look at the patents that have been filed already, they're like, if you had a magical sensor that detected potassium, you could do RASI optimization. You can do diuretic titration. That's it. So we believe that the core technology is defensible and total white space. It's just the use cases that they're trying to capture. And because they've been working on this, by the way. All of them have been working on this for more than 5 to 10 years now. And no output from them.
We'll go Lisa and then Dr. Ali.
So who's getting this when and for how long? Is it when the patient comes in with the problem, you put it on them, and then how long are they wearing it, or
Yeah.
is it continue? What is your thinking on that?
Yeah, so I talked a little bit about this on the business session yesterday. So basically, it's going to depend on use cases, and we are going to file for different use cases and different ways to do this. Now, in general, the first wear time will be 3 days, and what we're targeting is basically on CKD patients who are on first titration of a RASI, for instance, get your first 3 day, and then maybe you send another patch on day 10 to capture that, okay, and that'll cover you for 2 reads. Eventually, we're going to get to 14-day wear time, just like how CGM got from 3-day down to now 30-day. We're going to follow that same trajectory, and it's not rocket science. It's manufacturing process. You just need to get perfect manufacturing process. It takes several years to do that.
Dr. Ali?
So two-part question. Once you get to 14 days, where is your targeted patient? I mean, so looking at electrolytes, it's a wide variety. Are you specifically going deep on heart failure? Is it dialysis patients like you showed?
Yeah.
And then the second part, which goes along with potassium, is the potassium-sodium co-transport. So are y'all looking at other electrolytes? Potassium is part of it, very important, can cause death. But hyponatremia is also a big problem in our patients with heart failure, hypertension as well.
Yeah, so sodium just as important as potassium. The problem with sodium, and the reason we're not addressing that first, is because we don't believe serum sodium says anything about fluid management. It's the ISF sodium, which we can capture, which says a lot, but that creates a scientific problem. If we don't have a gold standard to compare to, what we have to compare on sodium is measures of peripheral fluid, so maybe it's something like impedance, maybe something like CardioMEMS, who knows. But that's going to be a later problem. Now, as for the 14-day, who are we really targeting for 14 days? I think the first one has to be patients who have to be diverted away from dialysis. So right now, there's a big problem with patients when they go on dialysis. There's a significant morbidity mortality. Survival curve is bad. Now we're seeing the Monograms of the world, these sort of value-based care kidney companies who are trying to save money by not going through dialysis. They're getting shunted to this other pathway where they're getting RASIs and diuretics. So that's pretty interesting, right? Because now you actually have to measure daily hypo and hyper. You're titrating both. And that's a really tight space to really play around with. 14-day on that, I think, would be incredibly powerful. So first CKD and then second GDMT.
Right. Yeah.
Can you share data on, on human use? Can you tell us about human use?
So what I can tell you right now is that we have first-in founder, quote unquote. We can't show that kind of data. I would not want to show my friends and family founder data. So our first-in-human is actually launching in about 1 to 2 weeks in Uzbekistan, pending ethics committee approval, and that is going to be the hemodialysis curve that I showed you. And so that's going to be quite an elegant study. It'll be Q15-minute reads on a peripheral catheter to check for potassium with simultaneous reads from our voltage channels and calibrated back to what we think the potassium should be. So we will have data to share probably in about 1 to 2 months. We've got a scientific newsletter. If anybody wants to know, go to our website, follow us, and we'll hopefully be able to share some data on that in 1 to 2 months.
Lisa.
So how does it actually change the treatment paradigm? I mean, if you're going to treat them when they come to the office,
Yeah, so this is not about changing the treatments patterns because those are guideline supported. We are trying to enable them. So the enablement part is specifically in the biggest problem right now. I had a graph yesterday showing that up to about 83% of patients who have their first hyperkalemic event are deprescribed off of these medications. So if you deprescribe off this medication, 83% are not having a follow-up potassium, but 30% are deprescribed and 30% more are underprescribed. What we believe is that's not what you should be doing. You should actually be keeping them borderline hyperkalemic. So the idea is to be permissive with the hyperkalemia. If you have a lot of that data, you're able to know, are they entering danger zone hyperkalemia or safe hyperkalemia? This is similar to stroke, where we developed a paradigm around permissive hypertension. And what was the difference there? It was we got a ton more data about blood pressure when the patients had strokes. We believe the same thing's going to happen with heart failure, amongst other disease conditions. We'll get very comfortable. How do I feel so comfortable about that? If you talk to nephrologists, they're already comfortable with hyperkalemia. It's just the rest of the primary care doctors, cardiologists, the rest of the world, we're not yet comfortable. We need that data. The nephrologists, they see their patients every month. To a primary care doctor, they don't know. They pull the trigger back on these medications that are bending, that are saving, years on these patients' lives because they get scared of this potassium issue.
Please.
So for patients with diabetes, do you envision that they would wear both the CGM and this device?
Great question. So what's interesting about diabetes is actually there's an interesting physiologic triangle between insulin, potassium, and glucose. And actually, if you could get all three, that would be amazing. Now, insulin's going to be a little hard. Glucose, easy. It's commoditized now. In fact, we have a prototype form factor that measures both glucose and potassium. I think that's going to be transformative, especially for diabetes type 2 patients sliding into CKD.
I think that's all we have time for. Thank you so much. Round of applause, please. Thank you. Eitan. Very good. Judges, time to calculate, make your decisions. I'd like to call up Reoxtech. Do you want to do your final pitch? Anyone? You don't want me doing it. I'll tell you that much. Oh, there you are. Sneaking up on me, yeah.
I figured I'd get even.
That's good. I appreciate that. Yeah, in advance. Outstanding. Are we all ready to get going? All right, 7 minutes on the clock. Very good.
Okay, hello, I'll get started. Sorry, I sound like I'm yelling. Apologize. Okay, how do I advance? Green? Okay, hi, my name's Neil Thomas. I am a cardiovascular surgeon. Please don't hold it against me. Right. I am the founder and the principal inventor of this technology that we want to share with you today. Essentially, what we have created is a isolated coronary perfusion device for the cath lab. My teammates tell me not to call it a cardioplegia device, but that's essentially what it is. The problem, of course, is reperfusion injury. And within the constraints of the door-to-balloon paradigm, we've seen a lot of additional damage. About 80% of patients after ST elevation MI have either microvascular obstruction or delayed microvascular recovery, and that is really a big problem because we know that it correlates with poor prognosis. I won't spend a lot of time on this slide, but basically it shows a depiction of a kinktos, which is supposed to mean that's the period of ischemic injury, followed by unmitigated exposure to both oxygen and flow. As a result, we know that within the constraints of door-to-balloon, the current treatment is opening the artery as quickly as possible to restore highly oxygenated arterial blood to the area at risk. The door-to-balloon paradigm has been unchallenged for many decades until very recently. But even those challenges have created data-driven confusion and a conundrum because they expect the operator to wait, to cause a waiting period between the time they get to the lab and opening the artery. Obviously, morbidity and mortality is still high, and it's clear that reperfusion injury accounts for up to 50% of the damage we see. So our solution is to take over total control of the coronary artery that allows the operator to re-oxygenate slowly, gradually over a period of time, and gradually reintroduce normal flow, but without the waiting period. So just as a frostbitten extremity is warmed gradually, we're doing this a little bit more gradually. Here's what the main iteration of the system looks like. Essentially, we deploy a catheter, proprietary catheter, to the infarct artery, which is the guide catheter. There's pre-dilatation. The operator is expected to obtain both venous and arterial access, which flow to the pump, as you can see down in the left panel on the bottom. The pump also integrates crystalloid so that the diluted mixed output avoids overcalcification as well. This integrates into standard workflows. It'll be familiar to most interventional cardiologists, to all interventional cardiologists. It uses the patient's own blood, and it doesn't require an oxygenator, which is a real advantage because the oxygenators upregulate a lot of inflammatory pathways. And there's a minimal impact on door-to-balloon time. The value proposition, we talked about a little bit at the business session yesterday, but basically we want to reduce morbidity and mortality. And the costs associated with cardiogenic shock, deterioration of function, high rates of readmission for heart failure. One of the previous presenters showed the outcome of a really big anterior MI that led to heart failure with reduced ejection fraction. Our internal work has shown that all of those complications are reduced. I'm going to show you a little bit of that data, but also that the need for expensive defibrillators is reduced. We are going to focus on cardiogenic shock first. If you look at all the randomized trials, with rare exception, and all the studies that have been published previously, they exclude patients with cardiogenic shock when they're trying to show benefit for a reperfusion injury therapy. So again, these patients are very costly to take care of. 50% of them die in the first year. I'll move on to a little bit of the science. I focus on the accumulation of sodium ions in the intracellular space, which is exacerbated by the turning on of the sodium proton exchanger, and that sets the stage for this type of injury. In June of this year, I presented our data at the Society of Thoracic Surgeons Coronary Conference. We reviewed in a retrospective cohort study data from about 120 patients. The marginal mortality rate was markedly reduced. That effect was enhanced in the shock patients. We showed improvement of about 10% in ejection fraction over the first 3 to 6 months. Readmission for heart failure and ICDs were reduced. This is from a series of pig experiments that we did this summer. I'll call your attention to the right panel, which showed a reduction in infarct size as measured as a ratio of the area at risk. This showed about a 41% relative risk reduction and about a 28% absolute risk reduction. The left panel here shows a classic analysis of response profile, which was looking at the trajectories of injury markers at troponin levels, in this case, cardiac troponin. And the most important scientific question here is whether the group times time interaction term is statistically significant, and it was. And in the right panel, you can see that at all times, the controls had larger infarct, again, as a ratio of the area at risk. So I'll stop there.
Well done. Well done. Ahead of schedule.
Yeah, you didn't have to sneak up.
I didn't have to sneak up on you. Like, make my job easy at the end. If we could put 7 more minutes back on the clock, and let's go to questions. Looks like Ken has a question right off the bat.
Yeah, so I'm not that familiar with this space. From an economic value proposition standpoint, reimbursement pathway, are there established codes you can leverage today, or do you have to go after a new code?
So again, I have a little bit of a disadvantage because I'm not an interventionalist. But I think there are codes that we could tack onto. There's also another company in this space that is using a coronary perfusion device downstream of where we are intervening. They're infusing supersaturated oxygen as kind of in the paradigm of kind of the myocardial infarction as a wound. And there is a reimbursement code for that that's FDA approved. But that works downstream of where we're trying to intervene.
Dr. Peterson? Oh, sorry.
In the patient data you showed, how many patients were there?
We reviewed 120 charts. We excluded some. I think we had about 70 at the end, 45 or so in the experimental arm, and the rest were historical controls, basically. It was a retrospective study that we did the analysis on. Yes, sir.
So I'm curious how long it takes to place this circuit.
My sense of it is just the rate-limiting step will be establishing access of both the artery and the vein. And then, of course, the guide catheter is just inserted in the same way an interventional cardiologist would insert any guide catheter. So the guide catheter has a proximal occluding member, which allows total isolation without any contamination of the hyperoxygenated or even just relatively hyperoxygenated arterial blood. And we're literally giving venous blood into the infarct vessel at the beginning, and the operator has control ratiometrically of arterial mixing in. And again, we don't need the patient's lungs function as the oxygenator in this case.
Dr. McConnell?
Oh, yeah, super interesting. I guess I ended up with two questions. One, if you could re-explain sort of, you said it's a retrospective study, but it is using your device. And then the other sort of trying to figure out the workflow. The typical thing, right? The interventional cardiologist is trying to reopen the vessel. How is their reopening the vessel, timing with getting your system? What happens first? Are both things happening at the same time? Yeah.
I appreciate those questions, really good. So the retrospective cohort that we reviewed was a surgical cohort. I've been practicing this for about 25 years, a version of this very precise method that the device allows administration of. Cardioplegia in the open heart operating room is established science. And so we were able to manipulate the PO2 of the perfusate in the same way that a critical care physician would manipulate the PO2, of a patient's arterial blood by adjusting the FiO2 on the ventilator. If you remember when they brought in permissive hypercarbia, right? People were doing that on purpose to prevent lung injury. We're doing this on purpose, purposefully using deoxygenated blood to avoid that hyperoxic burst, which I think most people realize causes a lot of injury. So, and then if you don't mind, the second part of your question?
Yeah, how do you do the order of the PCI?
Yeah, so the advantage of our technology is that it doesn't disrupt that workflow. The guide catheter, which ultimately blocks native flow into the artery, is deployed. The predilatation balloon goes through that catheter to create the predilatation. Then it's backed out, and then flow starts immediately, but with venous blood, without contamination from the systemic circulation. It's a very surgical concept.
Dr. Murat?
Okay, so from what I understand, that was actually helpful, the questions and the answers. So you deploy the balloon. Do you need now a larger French size to deploy your technology, and do you adapt it to existing guide catheters, or you need to have a custom-made guide catheter for that?
Yeah, well, our cardiology consultant couldn't be here today. It would be a better question for him, but basically, no. We think that a standard guide catheter, what are they usually, 8 French, 9 French, would be fine, and we can use we can put our predilatation balloon through that. Our guide catheter will be very similar, if not identical, in terms of French size. The only difference is that it has this balloon to occlude. Let's say you took over control of the left main. You occlude the entire left main and flow through the catheter. Now, we know from our studies this summer that we can do this in large animals. So this large animal model is very well accepted. We used mid-LAD occlusion, but the proximal balloon can occlude the artery and keep the pig alive for as many hours as we want, and certainly until the end of the experiment. We had a lot of fun proving that we could do it.
Judges, any other questions? Final questions? All right, well done. Thank you so much. Round of applause. Very good. All right, judges, I believe you have the opportunity to go back and relook at your scores and do your final submission. But in the meantime, we have another special treat. I'm going to call up my friend Allison again. Here you go, Allison.
Thank you.
You guys have been sitting for 90 minutes. I know, because I've been standing for 90 minutes. So
Feet must
please.
be tired. So we're actually going to sit a little bit longer because our exercise today is seated. Do you want to chair? Here you go. Okay. Just a quick review from yesterday. So these exercises are 1-minute bursts of exercise split up throughout the day. They can help boost your epinephrine, growth hormone, glucagon, cortisol. It helps with focus, mental acuity, and it can also help grow your mitochondria over time. So we're going to do these exercises, and I just want to demonstrate this. So I want everybody to kind of get forward on the edge of your seat. And if you're standing in the back, you can just follow us with your arms. So you're going to tap the balls of your feet on the floor like this, okay? So everybody just tap the balls of your feet. And then I also want you to engage your arms like this. So these are ones that you can just do at your desk. If you want to push back from your desk and do this for 1 minute, this is a great brain break. All right, and then we're going to cue up the music, and we set the timer for 1 minute also. Love this song. Okay, on your mark, get set, go. So I want you to tap the balls of your feet on the floor as fast as you can. This is really going to target your hip flexors as well, okay? Now we're going to move over to the side. This is going to help get your lats, okay? As fast as you can, come on. Push it, guys. Come with me, let's go. All right, switch. This is going to get the other side of your lats. You guys look amazing out there. Way to keep it up. And we're halfway done. We're starting to get tired. Bring it on home. Okay, I want you to engage your core. Try to tighten your abdominals while you're doing this. This is going to help build up your abs, okay? All right, now up top. You guys look awesome. Let's go, let's go, let's go. All right, home stretch, 10 seconds. Come on, let's go. Give it everything you got. Final sprint, 5 seconds. Good job, you did it. So as a reminder,
She enjoyed it.
to know that you've done this right, you're going to be a little winded, like I am. This respiration is a very important part of burst exercise. You got a cramp? No, I'm all right. So you want to have high respiration. Your muscles will be burning, and you might feel a little sweaty from the effort and the epinephrine you just got. So thank you so much.
Thank you, Allison. And what's the name of your company, Allison?
Burst Fitness.
Okay. All right, everybody. So 4:15, we'll come back here. Star Jones and Nancy Brown are going to help us give out the awards. Who could be the winner? I don't know. We'll see you soon. Thank you.